I think I will begin now.
Yes.
Yeah, it's already 7.
Ya, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat malam, salam sejahtera untuk kita semua. Kepada yang terhormat Dr. Agus Dwi Susanto, spesialis paru konsultan, selaku Ketua Umum Perhimpunan Dokter Paru Indonesia, yang sekaligus akan menjadi moderator pada webinar malam ini. Yang kami hormati, Country Manager dari Hetero, Mr. Sandip Sur. Yang kami hormati, para narasumber, Profesor Dr. Syam Sundar, Bachelor of Medicine, Bachelor of Surgery. Dr. Erna Burhan, Master of Science, spesialis paru konsultan. Yang kami hormati, para dokter dan tenaga kesehatan yang telah meluangkan waktu untuk mengikuti webinar pada malam hari ini. Selamat datang juga kami ucapkan kepada para peserta dari Myanmar dan Filipina yang turut bergabung dalam webinar ini. We also welcome the participants who are joining from Myanmar and Philippines. We hope you will enjoy this webinar. Perkenalkan, saya Ibrahim Darmawan yang akan memandu acara pada malam hari ini. Alhamdulillah, puji syukur kita panjatkan kehadirat Allah Subhanahu wa taala karena atas berkat rahmat-Nya kita masih diberikan kesehatan untuk berkumpul bersama dan menimba ilmu dari para narasumber yang luar biasa. Bapak, Ibu, para dokter dan tenaga kesehatan yang terhormat, pada malam ini kita akan mengikuti webinar yang mengusung tema ASEAN Expert Summit, New and Emerging Therapies in COVID-19, yang diselenggarakan oleh Perhimpunan Dokter Paru Indonesia bekerjasama dengan Ikatan Dokter Indonesia, Kalbe, dan Hetero. Berikut saya bacakan susunan acaranya. Pertama, sambutan dari Ketua Perhimpunan Dokter Paru Indonesia, Dr. Agus Dwi Susanto, spesialis paru konsultan. Dilanjutkan dengan sambutan dari Country Manager Hetero, Mr. Sandip Sur. Dilanjutkan dengan sesi materi yang akan dimoderatori oleh Dr. Agus Dwi Susanto, spesialis paru konsultan. Dengan materi pertama, Management of COVID-19 and Emerging Therapies oleh Profesor Dr. Syam Sundar. Dilanjutkan dengan materi kedua, COVID-19 Treatment Perspectives in Indonesia oleh Dr. Erna Burhan, Master of Science, spesialis paru konsultan. Diakhiri dengan diskusi panel yang akan dipandu oleh moderator, dan dilanjutkan dengan closing remarks oleh Dr. Syam Aku sebagai Head of Medical Marketing Hetero. Sebagai informasi, tiga penanya terbaik pada sesi diskusi akan mendapatkan hadiah spesial. Karena itu, siapkan pertanyaan terbaik Anda. Untuk pertanyaan yang ditujukan kepada Profesor Syam Sundar bisa menggunakan bahasa Inggris, sedangkan untuk Dr. Elina bisa dengan bahasa Indonesia maupun bahasa Inggris. Semua pertanyaan bisa dikirimkan melalui link kirim pertanyaan yang ada di browser Anda masing-masing dengan mengetikkan nama, institusi, dan pertanyaan Anda. Agar acara berlangsung dengan lancar dan bermanfaat bagi peserta yang hadir, marilah kita buka webinar ini dengan bacaan basmalah. Bismillahirrahmanirrahim. Baiklah, kita memasuki acara pertama, yaitu sambutan dari Ketua Umum Perhimpunan Dokter Paru Indonesia, Dr. Agus Dwi Susanto, spesialis paru konsultan. Kepada Dr. Agus, kami persilahkan.
Selamat malam semuanya. Assalamualaikum warahmatullahi wabarakatuh. Good evening and good night in Indonesia. Kita malam ini akan mendengarkan webinar yang tentunya sangat update sekali mengenai bagaimana tata laksana COVID-19 khususnya penggunaan antivirus yang sedang ramai dibicarakan di media di Indonesia. Kita ketahui bahwa COVID-19 sudah 7 bulan dan ini adalah kali pertama salah satu obat yang disinyalir memberikan dampak yang positif di dalam tata laksana COVID tersedia di Indonesia. Meskipun itu bukan suatu obat yang spesifik untuk COVID-19, tetapi uji-uji klinis menunjukkan hasil yang positif. Perhimpunan Dokter Paru Indonesia sangat berterima kasih kepada PT Hetero yang sudah mensupport kegiatan untuk menyelenggarakan webinar ini di hari Sabtu malam, ya. Dan tentunya sambil santai para peserta dapat mendengarkan ilmu-ilmu yang update di dalam penanganan COVID ini, khususnya bagaimana peran remdesivir di dalam tata laksana COVID-19. Terima kasih saya ucapkan kepada para speaker, Dr. Erlina Burhan. Thank you very much to speaker Dr. Shamsudar from India.
Thanks.
Because coming to our webinar in Indonesia. Thank you very much, and I hope you enjoy in our webinar this night. Terima kasih kepada panitia tentunya dan juga kepada sponsor PT Hetero yang telah bersedia untuk mensupport kegiatan PDPI malam hari ini. Semoga apa yang kita lakukan pada malam hari ini akan memberikan banyak hal positif yang tentu aplikatif dan juga membantu pasien-pasien COVID Indonesia khususnya di dalam menurunkan angka mortalitas dari kasus-kasus berat dan kasus-kasus kritis. Saya rasa cukup sambutan dari saya. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih atas sambutannya, dokter. Next, we will have the opening remarks by Heteros Country Manager. Please welcome Mr. Sandip Sur.
Selamat malam. Good evening, everybody. I am Sandip, Country Manager of Hetero. Hetero, basically, I am representing Amarox, PT Amarox, which is a subsidiary of Hetero from India. And first of all, I would like to say thanks to PDPI, who was giving the opportunity to host this event today evening. And along with me, I have several colleagues. My regional colleague, Dr. Sham, he is the head of medical marketing from India. He is responsible for the Asian market. Then along with me in Indonesia, I have my medical manager, Dr. Devi, then my senior product manager, Muheni, and also a few of my field staff who are already part of this event. So as you know, this is not the first event we are doing with PDPI. I think this is our second or third event. We started with oncology event. Dr. Agus remembers very well when we started, we said that this is going to be a continuous process with us. So, and special thanks to Dr. Agus for taking his valuable time out for this event. Dr. Agus, thank you very much. And my special thanks to, of course, Dr. Erlina. Dr. Erlina has been a part of us now. I mean, she has been part of our event a few days before. She was in our press conference also when we launched our officially in the media. And sooner or later, she will be also part of our trial, which is going to happen in Indonesia. And our guest speaker from India, Dr. Sham Sundar from Banaras Hindu University. And I know that university very well. I have visited that university, so I have a great respect for that university. So thank you, Dr. Sham Sundar, for accepting our invite. And coming to our main part, you know that Hetero or Amarox has been given the first approval of Remdesivir or COVID-4, our drug in Indonesia. We are the first one to get the EUA approval from BPOM. And we are very proud that, you know, we have been able to bring this product to combat the pandemic of COVID-19 in Indonesia. We are taking initiatives to support the government, you know, to bring down the challenges of handling or combating the COVID-19. Just to give you a brief about Hetero, Hetero is a global multinational company. It's a vertically integrated company. We manufacture right from API till finished goods. And we have presence in more than 100 countries globally. And we have 36 state-of-art manufacturing facility. COVID-4, which is imported from India, from Hetero, is also manufactured in a US FDA approved plant. So the product which you are getting in Indonesia is also under license from Gilead, but also manufactured in a US FDA approved plant. Apart from COVID-4, which is for the pandemic COVID-19 antiviral drug, which is being used, Hetero is also very commonly known or famous for antiviral drugs, antiretroviral drugs. We are also having a big presence in oncology, cardiovascular, hepatitis. So we have more than 300 molecules in our portfolio, including respiratory also. So Hetero is a company which is a globally known company. Previously, we used to work mostly with B2B model, but now we also present in B2C. In Indonesia, we have a presence. We have a company, I mean, joint venture company. We call it PT Amarox Pharma Global. And we have launched, apart from COVID-4, which we have launched recently, we have also to combat COVID-19, we have oseltamivir, which we have already supplied to the government, Ministry of Health. and it's also available in the market. Then we also have Lopirito, which has been approved by BPOM. Product should be available in the market from the month of October. And apart from that, as I told you, that we have a presence in oncology, where we have products like erlotinib, pemetrexed, which is used for lung cancer. Then we have a temozolomide for glioblastoma. Then we also have imatinib, which is for CML. Then we also have some products like rosuvastatin, atorvastatin, pregabalin, quetiapine, some antibiotic, vancomycin. So we have a wide range of products, and we have a plan to introduce more and more new products in the country. So I really, really thankful to PDPI and all the speakers here for taking their time out. And also I would like to say thanks to the other countries like Philippines or Myanmar, whoever is joining this webinar. Hopefully you will get to know the perspective from different speakers from Indonesia as well as from India. And of course, Dr. Sham will give his valuable input about COVID-4 from Hetero. So without taking much time, I would like to say thanks once again. And I look forward to get support from all of you in future. And I'm very hopeful, or you know what, you can very confident in future to Hetero or PT Amarox will contribute by bringing good products with the affordable price and quality product in Indonesia. That will definitely help the government initiative to combat the COVID-19 pandemic in the country. So thank you very much.
Thank you, Mr. Sandip. Baiklah, kita memasuki sesi yang ditunggu-tunggu, yaitu pemaparan materi oleh narasumber yang akan dipandu oleh Dr. Agus selaku moderator. Berikut saya bacakan kurikulum vitae beliau. Untuk Dr. Agus Dwi Susanto, spesialis pada konsultan, menyelesaikan pendidikan dokter umum, dokter spesialis, dan program doktoral di Universitas Indonesia. Saat ini beliau menjabat sebagai Ketua Umum Perhimpunan Dokter Paru Indonesia dan Ketua Departemen Pulmonologi dan Kedokteran Respirasi Universitas Indonesia. Dr. Agus juga aktif sebagai anggota Asian Pacific Society of Respirology dan Perhimpunan Bronkoskopi Indonesia. Beliau juga menjabat sebagai Ketua dari Pendidikan Kedokteran Berkelanjutan dan Ketua dari Kedokteran Paru Kerja di Departemen Pulmonologi dan Respirasi Fakultas Kedokteran Universitas Indonesia. Kepada Dr. Agus, waktu dan tempat kami persilahkan.
Terima kasih, selamat malam, good evening. Kita akan mendengarkan paparan dari dua pembicara yang sudah terkenal tentunya di India dan juga di Indonesia. Ada dua topik yang akan dibawakan oleh peserta. Yang pertama akan dibawakan oleh Dr. Syam Sudar, yaitu mengenai Management of COVID-19 Emerging Therapy. Dr. Syam Sudar adalah visiting professor dari Jawaharlal Institute Postgraduate Medical Education Research. Beliau tentunya sudah terkenal di India dan sudah banyak mendapatkan award ya di situ, seperti Anna Morgency Award tahun 2010 from Geneva, Switzerland. It's a Fellowship Infectious Disease Society of America. Kemudian beliau juga fellow di Royal College of Physicians London, fellow World Academy Science Italia, fellow of American Society of Tropical Medicine HIZIN. Beliau banyak mendapatkan award dan sekarang ini adalah jabatannya sebagai, beliau banyak publikasi ya, hampir 913.000 dengan H-index 90, citasinya lebih dari 33.000. Saya rasa sudah sangat expert, sehingga ini kesempatan kita untuk mendengarkan pembicara dari India. Good evening, Professor Syam Sudar. This is your time to give a lecture about your topic. Thank you.
Thank you, Dr. Susanto. So, should I share the screen? I can't share the screen. अरे बाहर जाके बात करो.
So do you want me to help with that?
Yeah, please.
Yeah, 1 second.
Thank you, Dr. Susanto, for your kind words. I'm really delighted to be part of this meeting and very happy to speak about management of COVID-19. Can I have the next slide? Next slide.
Is this okay?
It's not full screen.
Yeah, click enable editing and then play in the full screen mode.
Enable editing from where?
On top, there is an enable editing, a yellow bar.
Yeah. It doesn't click.
Priya, you're displaying the slides, right?
Yeah, sir.
So go on to the next slide. Make it.
Is it full screen now?
Yes.
Okay. Should I go on to the next slide?
I cannot see anything.
Yes, I cannot see anything in the slide. Is there any problem?
Is it visible now?
Yes.
It was visible, then disappeared again.
Click next. Priya, can you click next?
Yeah.
No, it's
Hello.
Hello.
Is there any problem?
Is it visible now?
no,
Yes.
no.
Then disappeared again.
Click next. Priya, can you click next?
Yeah, visible now?
No, the slides are not visible, Priya.
I can see them from your. Give me 1 second.
Or can Dr. Shyam Sundar share his screen once again with the PPT?
Yeah.
Priya, can you stop sharing and
Yeah, I'll stop.
yeah. Dr. Shyam Sundar, can you try sharing your screen once?
Okay. When I this, yeah. Can you see now? Can you
Yes.
see now?
Yes, it is visible.
Okay.
Yeah, please play the full screen mode.
It is full screen now.
Okay, that's okay. We can read and we can see. Just go ahead.
Okay. So thanks again. I mean, all of you know that COVID-19 is a viral respiratory disease caused by severe acute respiratory syndrome coronavirus, which we call COVID-19 or SARS-CoV-2. It causes wide spectrum of illness, starting from asymptomatic, which are majority, or mild illness, to severe respiratory failure and death. And so about 20% patients have to be admitted in ICU. It can cause multiple serious complications, leading to severe inflammatory response, and acute respiratory distress syndrome, nephrotoxicity, liver injury, cardiovascular complications. There is no drug so far registered to treat COVID-19, and a vaccine is not yet available. Management is based on supportive therapy, symptomatic treatment, and preventing the respiratory failure. The most important step is to isolate the infected individual to prevent further spread of the virus. This virus is very efficient in transmitting to others. It is very contagious, and man-to-man transmission is so far known. So we have to isolate the patient. Of course, maintain hydration and nutrition. Antibiotics if you suspect infection, bacterial co-infection. Hypoxia, if there is hypoxia, deliver oxygen through nasal prongs, cannula or face mask, or non-invasive ventilation. And finally,
Dr. Sham, we cannot see your slides moving.
Can you
At the first
next slide, Professor Sam? Because the slide not moving.
now?
No.
No, still on the first slide.
But in my
Dr. Sham, can you just click escape button and see? Yeah, can you move the slide now?
Yeah, it's already moving.
Yeah, it's moving. Yeah. Yeah, please keep it in. Yeah, this is okay.
This is okay?
Yeah, this is okay.
So, as I said, mechanical ventilation and oxygen support may be needed. How do you manage mild cases? As I said, majority of the cases are either asymptomatic or with very mild disease. So you have to manage these patients at a COVID care center at the basic level, or community health center, or even district hospitals. Measure daily temperature, vitals, and oxygen saturation, which is very important. And symptomatic treatment, antipyretics like paracetamol, and antistressive for cough. Ensure adequate nutrition and appropriate hydration. Management of moderate cases, isolated in dedicated COVID health centers or district hospital or medical college hospitals, but slightly higher expertise it needs. Detailed clinical history, including comorbid conditions, because diabetes and heart disease, etc., can really complicate the outcome. Measurement of vital signs, partial pressure of oxygen, radiological examination of X-ray chest, which is very important. This can give you first clue of respiratory involvement, complete blood count, and other investigation. Here also symptomatic treatment is important against the same drugs, and then adequate hydration and oxygen support. To target the SpO2 to 92 to 96, and slightly lower in patient with COPD. Awake proning may be used as a rescue therapy, and this helps in functioning of the lung. Daily electrocardiogram, then prophylactic dose of UFH, unfractionated heparin, or low molecular weight heparin. I will be coming to that in detail. Then corticosteroids, again I'll discuss this. Then you may consider remdesivir, which is nowadays which is being used as emergency emergency use authorization, and convalescent plasma. Again, I will be discussing. You have to monitor CRP, D-dimer, ferritin. They are all acute fat reactants, and they say that higher they are, the patients may go into severe COVID. CBC with differential count, then absolute lymphocyte count. Again, there is a lymphopenia in this disease. So that is a one indicator of the prognosis of the case. And then of course, liver function and kidney functions. Management of severe cases. Again, symptomatic treatment has to be given. Oxygen therapy initiated 5 liters per minute and titrate to reach the target of 90% oxygenation in non-pregnant adults and 92 to 96 in pregnant patients. Again, fluid management in patients with no evidence of shock, high prophylactic dose of heparin, then corticosteroids and tocilizumab. Management of hypoxemic respiratory failure and ARDS. Patient with respiratory distress failing standard oxygen therapy are switched to high flow nasal oxygenation or non-invasive ventilation. In NIV setting, tidal volume should be 5 to 7 ml per kilo with PEEP of 5 to 10 centimeter of water, and fractional FiO2 0.5 to 1 titrated to target the SpO2 of 94%. If condition doesn't improve, within 1 to 2 hours, initiate intubation, mechanical ventilation using lower tidal volumes and lower respiratory pressure. Then prone ventilation again here is helpful. If you can do, make the patient prone for 16 to 18 hours a day. Now, management of septic shock. Septic shock occurs, there are two, one is cytokine storm. So I will discuss that separately. But here it is, if there are secondary infections, and then you have these patients who require vasopressors to maintain the arterial pressure of 65 millimeter of Hg or lactate of 2 millimole per liter in absence of hypovolemia. Mind it, in absence of hypovolemia, these are the features suggestive of septic shock. Then antimicrobial therapy with fluid loading and vasopressors for hypotension. At least 30 ml per kg of isotonic crystalloid in adults in the first 3 hours should be given. Now coming to specific therapies. Corticosteroids, and according to WHO routine, systemic corticosteroids are not recommended outside the trial setting. In India, recommendation is to use this moderate to severe stages beside other therapeutic measures. You should know that steroids are helpful only in moderate to severe stage of illness, not in the mild illness. And then, of course, there is a decreased likelihood of death among patients of COVID who receive methylprednisolone, and this was published in JAMA. Earlier, on 1st September 2020, NIH panel made some recommendations about corticosteroids in COVID-19, and they recommended using dexamethasone at 6 milligram per kilo for 10 days in patients with COVID-19 who are mechanically ventilated. It was shown that maximum benefit occurred of steroids in patients who are mechanically ventilated. Patients with COVID-19 are who require supplemental oxygen, but who are not mechanically ventilated, but they require supplemental oxygen. These are the two groups of patients whom corticosteroids should be given. It recommends against using in patients who do not require supplemental oxygen. So it can be harmful. If dexamethasone is not available, other corticoids like prednisolone, methylprednisolone, or hydrocortisone can be used. Now coming to the cytokine storm, there is a severe cytokine activation leading to rapid onset hypoxemia, shock, and multi-organ dysfunction, and can lead to death in some of the patients. There may be higher neutrophil count, elevated C-reactive protein. Of course, IL-6 level is very high, and tocilizumab is a humanized anti-IL-6 receptor antibody, which is proposed as a therapeutic agent in severe COVID disease. But I must tell you that so far there are no trials which to state the validity of the use of tocilizumab. Antecedent reports from Italy and China support the use of tocilizumab in this setting, but they are anecdotal. Specific therapies, coming to anticoagulation. Coagulopathy is a feature observed in this disease and is associated with high mortality. And it can affect cardiac vessels, it can affect renal vessels. So in addition to the pulmonary vessels, it can involve other organs also and lead to death. Patients should receive thromboprophylaxis in moderate to severe cases, and in moderate cases you give fractionated heparin, unfractionated heparin or low molecular weight heparin, enoxaparin 40 milligram per day subcutaneously, or high prophylactic dose of unfractionated heparin in severe cases, or low molecular weight heparin, enoxaparin 40 milligram subcutaneously BD. Convalescent plasma therapy may be considered in patients with moderate disease who are not improving. Oxygen requirement is progressively increasing despite use of steroids. The special prerequisites are that every precaution should be taken as we do in blood transfusion, and the neutralizing titer of donor plasma should be above 1:640 dilution. So it should have very high levels of antibodies. Recipient should be closely monitored for several hours post-transfusion or transfusion-related adverse outcome. Use should be avoided in patients with IgA deficiency or immunoglobulin allergy. Again, for convalescent plasma therapy, there are small anecdotal reports, nothing very, but now of course in USA, there is a trial which is going on and which target thousands of patients receiving plasma therapy. Then coming to this, again, controversial drugs like chloroquine, hydroxychloroquine or azathioprine. I saw two meta-analysis. In meta-analysis 1, the authors suggested that there are available evidence that chloroquine or hydroxychloroquine does not improve clinical outcome in COVID-19. Well-designed trials are needed to assess the efficacy and safety of these molecules. And then another meta-analysis which occurred, which appeared later earlier this year, is the hydroxychloroquine alone was not associated with reduced mortality in hospitalized patients. So this also said the same thing. And importantly, combination of hydroxychloroquine and azithromycin significantly increased mortality. So we have to be very careful when we are using these molecules. Then coming to antivirals, remdesivir. It is a prodrug of adenosine analog which inhibits RNA-dependent RNA polymerase, which is are present in the broad spectrum of RNA viruses, including COVID-19 and MERS. It is a novel drug developed for the treatment of Ebola virus, and actually this is a chance discovery that it also inhibits COVID-19. Remdesivir acts through incorporation in the nascent viral RNA chain and causes its premature termination. I'll come to the mechanism now. The triphosphate form of remdesivir is being used as a substrate for viral RNA-dependent RNA polymerase complexes. So what happens? This combination inhibits this enzyme, RNA-dependent RNA polymerase, and which inhibits RNA synthesis and by a specific mechanism of delayed chain termination for all the 3 coronaviruses. It has been observed that remdesivir triphosphate resembles specifically ATP, adenosine triphosphate molecule, and competes with nucleotide during the viral RNA synthesis. So actually, it's a inhibitor of this enzyme, the RNA-dependent RNA polymerase. That's a schematic representation. Here you can see that the virus has internalized, and then it starts making proteins using RDRP, RNA-dependent RNA polymerase. And now if we give remdesivir, it inhibits this enzyme so that it cannot produce now viral protein, and viral replication is stopped. And these are the proteins which are inhibited, or which are not produced after administration of remdesivir. Now, what are the clinical evidences? The National Institute of Health, they carried out a COVID-19 treatment trial with remdesivir, and here they took adult patients with one or more of these findings, like radiological infiltrates, partial pressure of oxygen less than 94 on room air, required supplemental oxygen, or required mechanical ventilation. The sample size was 1063, which is a good number, and there was a daily assessment up to day 19 and for time to clinical improvement while hospitalized. Primary endpoint was time to recovery by day 29, and secondary endpoint was treatment related improvement at day 15. So here are the results of these patients, and as you can see, the clinical recovery was much faster with remdesivir, 11 days as compared to 15 days of placebo, and which was an improvement of 31%, very highly significant, p less than 0.001. Although as far as mortality is concerned, the number suggests that this remdesivir is beneficial, 11.9% with placebo and 7.1% with remdesivir. However, unfortunately, because of the size, this is not significant, statistically significant, but it gives you some idea. Then there was another trial which was Gilead sponsored trial. It was a multicentric randomized open label phase 3 trial where remdesivir for 5 days was compared with remdesivir for 10 days. And as you know that on day 1, 200 milligram is given, and then day 2 to 500 milligram, and in 10-day course, day 2 to 1,000 milligram. Primary endpoint was clinical status assessed on day 14. Secondary endpoints were proportion of patients with adverse events after the first dose of remdesivir for up to 30 days after the last dose. So first was primary endpoint was efficacy, and secondary endpoint was safety. So what happened? What was the result? The result was that remdesivir for 5 days led to a higher number of patients with clinical improvement, 64% versus 54% with remdesivir. Again, clinical recovery 64% as compared to 54% on 10 days therapy. Mortality 8% in 5 days compared to 11 days of 11% of with mortality with remdesivir 10 days. So as you can see, almost every parameter was better with a 5-day treatment. So most of the people now think that remdesivir should be given only for 5 days rather than 10 days. what is remdesivir versus standard care in patients with COVID-19? Another sponsored by Gilead, by the makers of remdesivir. It was a simple trial, simple moderate trial, where multi-center randomized open label phase 3 trial was done. Primary endpoint was improvement on day 11, so efficacy, and secondary endpoint was adverse events. Patients with more than 12 years of age were included, and with those showing infiltrates in X-rays, and then partial pressure of oxygen more than 94, and room air at room air, and the number was 584. As you can see, roughly 200 patients were there in all the three groups. In remdesivir IV for 200 milligram, and then 5-day treatment 191, 10-day treatment 193, and standard of care 200. So these were the three groups which were studied. Clinical outcome was, I think you should not go with this busy table, but on the right hand side you can see that on day 11, patients in 5-day remdesivir group had statistically significant higher odds of a better clinical status distribution than those receiving standard care. Here you can see the p-value at 0.02 for 5-day treatment. Unfortunately, for 10-day treatment, it was not significant. So again, it goes on to say that 5-day remdesivir is better than 10-day remdesivir. In remdesivir in severe COVID-19, a study from China, which was a randomized double-blind placebo-controlled trial, which was a multicentric trial. Again, adults were taken, and these patients were taken with an interval from symptoms onset to enrollment 12 days, or less oxygen saturation of 94% or less, or a ratio of partial pressure of oxygen to inspired air was less than or equal to 300. So you know that partial pressure of oxygen is divided by 0.2, which is the inhaled oxygen, and it roughly around 500 should be the normal result. Here it is less than the threshold was less than 300, and radiologically confirmed pneumonia. The numbers were, this was 2:1 randomization, and where you can see remdesivir was given for 10 days. Again, the same scheme of treatment, and placebo for 10 days in 79 patients. And again, the primary endpoint was efficacy. And as you can see, those receiving remdesivir or placebo within 10 days of symptom onset in the ITT population, those receiving remdesivir had a numerically faster time to clinical improvement than those receiving placebo. Unfortunately, again, this difference was such that it was not statistically significant, and the difference was not very wide. Then coming to remdesivir for COVID-19 versus a cohort receiving a standard of care. This was again a study done in USA, and where actually patients from an ongoing phase 3 trial were taken for remdesivir cohort, and retrospective study was done for the non-remdesivir cohort. And as you can see here, that patients with recovery to 74.4% with remdesivir, whereas non-remdesivir had only 59%, and it was very highly significant statistically, p less than 0.001. Then as far as mortality is concerned, again remdesivir arm had much lower mortality, 7.6%, and non-remdesivir cohort had 12.5%. So difference was again very starking, very wide, and it was again significant, 0.001 p. So FDA approved it for emergency use authorization, and now in USA it is available for emergency use in patients, adults and pediatric patients hospitalized for suspected or laboratory confirmed COVID-19. Now in India, we are using COVID for 5 days, 200 milligram on day 1, and then 100 milligram daily for 4 days. It is again included in Indian protocol unless under emergency use authorization. It may be considered in patients with moderate and severe disease with none of the following contraindications. That is, there are normal renal function if the enzymes, hepatic enzymes are not very high. If the renal impairment is severe, then also you cannot use this drug. Pregnancy or lactating females, we don't have the data, so it should not be used. And children under 12 years of age. Then coming to favipiravir. Again, it is a RNA-dependent RNA polymerase inhibitor with antiviral activity against wide varieties of RNA virus. It has shown modest activity against COVID-19 with a pronounced cytopathy in virocell studies. So in vitro studies suggest that this salt has good activity against SARS-2 virus. Within the tissue, the molecule changes to phosphoribosylation to favipiravir RTP, which is the active form of drug. This molecule acts as a substrate for, again, RDRP enzyme, which is mistaken by the enzyme as a purine nucleotide, and thus inhibiting this activity and terminating viral protein synthesis. It gets incorporated into the viral RNA strand and preventing further extension. It's just a cartoon again, and where you can see that there is a penetration of the virus, and then this virus starts multiplying. Once favipiravir is introduced, it goes into the active form, favipiravir RTP, and this goes and inhibits this enzyme, RNA-dependent RNA polymerase, and then inhibiting the protein synthesis and inhibiting the multiplication of the virus. What are the clinical evidence of favipiravir? In the moderate COVID-19, there is a trial with phase 2-3 randomized clinical trial, multicenter, where favipiravir was given 1600 milligram BD on day 1 and then 600 milligram BD on day 2. This was the one arm. The second arm was favipiravir 1800 milligram BD on day 1 and then 800 milligram BD for 2 to 14. And this was a Russian study and a standard of control according to Russian guidelines. These adults were taken, men and non-pregnant women, and PCR must be confirmed. Of course, PCR confirmed were there. And the total number was not very high, 16. But you can see the result. At day 5, you can see that the proportion of patients who eliminated SARS-CoV-2. बंद करो निशा, 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 बंद करो उसको, फोन को. I'm sorry for the interruption. So then the time to normal. So it was on day 10. It was not significant because the patient on standard care also picked up, and the difference was only 12.5%, which was not significant statistically. Another important part was that favipiravir resulted in time to normal body temperature much lower as compared to standard of care, and the p-value was 0.007. So there was early recovery with favipiravir in this study. Patients were discharged from the hospital by day 15, where 65% on patients on favipiravir, 600 dosing, 85% of favipiravir with 1800 and 800 dosing, and 85% patients on standard of care. So you can see not very dramatic results. Adverse drug reaction were reported in about 18% patients, which included mainly GI, diarrhea, nausea, vomiting, then chest pain, and increase in the liver transaminase levels. Then this is a Japanese study where patients aged between 10 to 90 years were taken, which were on and favipiravir was used on a compassionate use, and the number was very high, 2,158. Favipiravir was dosed in 92.8% patients at 2 doses of 1800 milligram on the first day and then 800 milligram twice daily for another 13 days. So total 14 days treatment. Primary endpoint was again the clinical status at day 7 to day 14 with the use of from the start of the use of favipiravir, and clinical outcome after 1 month of admission. Secondary endpoint was safety assessment as in other trials. And here you can see after start of favipiravir, clinical outcome was in 7 days, mild 73.8% patients improved as compared to 87.5% after 14 days. So this was 7 days versus 14 days comparison in the mild patients. In moderate patients, 66.6% patients improved without favipiravir, and 84.5% patients with favipiravir. And similarly, in severe cases, only 40% patients improved on day 7, whereas 60% improved on day 14. So mortality rate after 1 month of hospital admission was 5% in mild disease, 12.7% in moderate disease, and a very high 31.7% in severe disease. And most common adverse event was hyperuricemia or liver function abnormalities with favipiravir use. I'm coming to the last slide. In June 2020, favipiravir received the drug controller's approval in India for mild and moderate COVID-19 infection for restricted emergency use. The dose in clinically used in most countries, including India, is 1800 milligram twice daily for day 1, and then for another 13 days, 800 milligram on days 2 to 14. So I have come to my end of my talk. Important thing is to note is that remdesivir is the only salt in which there are many clinical studies or randomized control trials are available, and they go on to underscore that remdesivir can be useful in moderate to severe disease, whereas favipiravir in mild to moderate disease. Thank you for your attention.
Thank you, Prof. Shamsudar, for your presentation. Next speaker is Dr. Erlina Burhan. Dr. Erlina Burhan is a former speaker from Indonesia. She is head of Indonesian Society of Respirology Jakarta chapter, and he also head of international relationship from Indonesia Society of Respirology, and also he of the chief of infection team of Indonesia Society of Respirology. So Dr. Elina, you can presentation your time 20 minutes.
Dr. Elina, please unmute yourself.
Okay, thank you, Dr. Agus. I was trying to talk about the update current guideline COVID-19 in Indonesia, but I do know that here all participants, almost vast majority of participants are from Indonesia. So please allow me to speak in Bahasa. Thank you. But my slide is in English, so Dr. Syam, you can follow. Ya, it has been known that sudah kita ketahui bersama bahwa coronavirus ini sudah merebak ke lebih dari 140 negara dan kasusnya selalu meningkat. Untuk Indonesia hampir 300, ini angka lama ya, hampir 300.000 sekarang, dan kematian juga hampir 11.000. Mungkin ini cukup tinggi kenaikannya, bahkan dalam 1 bulan terakhir ini angka pertambahan selalu di atas 3.000, bahkan pernah 4.000. Mungkin kita perlu juga tahu tentang definisi baru ya. Kalau dulu ada OTG, ODP, PDP, nah sekarang kita ikut definisi WHO, yaitu suspect, probable, confirm, dan close contact. Suspect ini adalah orang yang memenuhi kriteria, ada ISPA, kemudian ada riwayat perjalanan ke daerah yang banyak kasusnya, yang ada local transmission dalam 14 hari terakhir, atau orang-orang dengan gejala ISPA dan ada riwayat kontak dengan kasus yang terkonfirmasi dan juga kasus probable dalam 14 hari terakhir. Atau bisa juga orang-orang yang dengan gejala ISPA yang berat dan juga gejala pneumonia yang berat yang memerlukan perawatan rumah sakit, dan kita tidak bisa menemukan diagnosis lain dari orang tersebut, maka ini adalah termasuk kelompok suspek. Ya, jadi ISPA yang dimaksud di sini adalah bila terdapat demam lebih dari 38 derajat Celcius, kemudian ada gejala-gejala salah satu dari 5 berikut, ada batuk, atau mungkin ada sesak, atau nyeri tenggorok, atau ada gejala seperti flu, atau gejala-gejala pneumonia berat. Jadi salah satu saja ditambah demam itu sudah cukup menentukan bahwa ini ada ISPA. Kemudian yang berikutnya adalah definisi untuk probable. Jadi ini sedikit ada pembaharuan ya, bahwa yang termasuk probable ini adalah kasus suspek yang di atas tadi, kemudian meninggal. Ya, meninggal, gejalanya persis sangat-sangat sesuai dengan COVID, tetapi tidak ada hasil pemeriksaan PCR. Kalaupun ada 1 kali saja dan itu pun negatif. Tapi karena gejalanya sangat-sangat sesuai dengan COVID, maka ini masuk ke definisi probable. Nah, yang konfirmasi ini sudah sangat jelas sekali sekarang ya, bahwa konfirmasi itu harus dari RT-PCR, bukan dari rapid test. Jadi dianggap konfirmasi kalau positif dari PCR, dan sekarang yang konfirmasi ini dibagi 2. Ada yang asimptomatik, yang dulu disebut OTG, dan ada yang simptomatik. Jadi positif atau terkonfirmasi COVID dibagi 2, tidak bergejala dan dengan gejala. Ya, sekarang bagaimana definisi kontak erat? Jadi kontak erat ini adalah ada riwayat kontak dengan kasus terkonfirmasi atau maupun kasus yang probable. Dan kontaknya bisa tatap muka, ya, tatap muka dengan radius kurang dari 1 meter dan lebih dari 15 menit. Jadi kalau ada kontak dengan yang probable atau konfirmasi, tapi radiusnya lebih dari 2 meter dan mungkin hanya 1 menit saja, itu tidak termasuk kontak erat. Jadi ada definisi khusus ya. Kemudian juga kontak erat itu adalah orang yang berkontak secara fisik, secara langsung, misalnya berjabat tangan, berpegangan tangan, dan lain-lain. Dan juga memenuhi kriteria lebih dari 15 menit. Dan juga sebetulnya petugas kesehatan bisa dianggap kontak erat bila mana tidak memakai APD yang benar. Ya. Oke, selanjutnya adalah pembagian atau klasifikasi keparahan penyakit. Itu ada 5 ya. Sekarang ada 1 asimptomatik atau tanpa gejala, 2 ringan, berikutnya sedang, berat, dan kritis. Yang ringan seperti apa? Jadi yang ringan itu adalah kasus-kasus yang tidak ada bukti pneumonia, artinya pneumonia ini harus hasil fototorak yang ada lesi ya, kemudian tidak ada tanda-tanda atau bukti dari hipoksia, jadi mungkin hanya demam, batuk, anoreksia, mialgia, agak sesak begitu ya. Dan bisa juga ada gejala-gejala yang tidak spesifik seperti nyeri tenggorok, hidung tersumbat, sakit kepala, diare, nausea, muntah, anosmia. Nah, ini agak banyak sekarang ya anosmia atau agesia. Agesia adalah penurunan kemampuan untuk mengecap. Dan juga ada beberapa simptom yang tidak khas, umumnya pada orang-orang yang dengan imunokompromis atau pasien-pasien tua. Nah, ini masuk kelompok yang ringan. Sementara yang sedang adalah orang dewasa dengan tanda klinis berupa pneumonia disertai dengan demam, batuk, sesak ya. Dan tetapi bukan yang severe pneumonia, artinya saturasi O2-nya masih di atas 93%. Dan untuk anak-anak biasanya adalah juga pas anak-anak yang tidak terbukti severe ya, dan tidak juga ada tanda-tanda bukti pneumonia yang severe. Yang kasus-kasus yang severe adalah remaja atau dewasa dengan gejala ada pneumonia serta salah satu dari 3 gejala berikut. Jadi 1 ada klinis pneumonia dan salah satu apakah itu frekuensi nafas yang di atas 30 kali per menit atau terlihat tanda-tanda respiratory distress, severe respiratory distress, dan atau saturasi oksigen di bawah 93%. Jadi salah satu dari 3 itu plus tanda-tanda pneumonia itu masuk ke severe. Untuk anak agak berbeda sedikit ya, bahwa kalaupun saturasinya mungkin sama, tetapi biasanya anak-anak ada salah satu gejala ya atau ini ya, jadi salah satu bisa tidak bisa menyusu, tidak bisa minum, terlihat sangat-sangat letih, sangat lemah, dan bahkan pada anak-anak yang mudah terjadi penurunan kesadaran atau kejang. Dan juga terlihat retraksi dinding dada saat bernafas atau takipne. Yang kritis ini semua kita tidak tahu adalah pasien-pasien yang dengan ARDS, ada tanda-tanda sepsis dan juga shock sepsis. Nah, bagaimana pengobatannya untuk yang pertama asimptomatik? Semua sudah tahu ini, sudah sering saya bicarakan ya, bahwa untuk yang asimptomatik atau tanpa gejala biasanya cukup dengan pemberian vitamin. Bisa vitamin C atau multivitamin yang mengandung vitamin C, B, E, dan zinc, dan juga sekarang bisa dengan ditambahkan vitamin D3 ya. Dan juga kalau ada komorbid, orang-orang yang asimptomatik ini harus komorbidnya diobati dan terkendali. Dan juga dapat diberikan supportive medicine ya, berupa obat-obat tradisional atau fitofarmaka atau obat modern asli Indonesia atau OMAI. Ini istilahnya sudah baku ya, OMAI, singkatan dari obat modern asli Indonesia yang sudah terregistrasi di Badan POM. Jadi kalau ada mungkin kita mengenal empon-empon, kalau itu tidak ada bukti registrasinya, mungkin tidak termasuk ke fitofarmaka ini. Tapi kalau ada registrasinya boleh dipakai ya. Dan juga obat-obat antioksidan boleh diberikan. Bagaimana yang dengan gejala ringan? Jadi ini bergejala tapi ringan, maka selain pemberian obat vitamin seperti yang saya sampaikan tadi, ya, atau juga supportive terapi. Untuk yang ringan ini juga ditambahkan dengan azitromisin dan bila perlu pemberian antivirus salah satu saja, tidak bersamaan nih ya, bisa oseltamivir 75 mg ini 2 kali sehari atau kombinasi lopinavir dan ritonavir atau aluvia ini bisa 10 hari 2 kali 400 mg ya. Kemudian bisa diberikan favipiravir atau opigan loading dose hari pertama, kemudian 1.600 dan selanjutnya 2 kali 600 5 hari berikutnya. Dan bisa diberikan juga obat-obat seperti paracetamol bila memang ada demam, dan mungkin dapat diberikan kloroquine atau hidroksikloroquine bila kita pasti tahu bahwa pasien ini usianya kurang dari 50 dan tidak ada tanda-tanda penyakit jantung. Tapi hati-hati ya, kalau di pasiennya rawat jalan ini, di buku pedoman 5 organisasi profesi untuk rawat jalan hidroksikloroquine tidak kita berikan. Tolong diingat itu ya. Untuk yang sedang, nah yang sedang ini wajib dirawat ini ya. Dan pada yang sedang obat-obatnya sebenarnya sama, karena dirawat obat-obat bisa diberikan dengan intravena, dan karena dirawat juga maka sekarang mengingat kita sudah ada remdesivir, maka salah satu pemberian antivirusnya adalah bisa oseltamivir atau lopinavir plus ritonavir atau favipiravir atau opigan atau remdesivir. Jadi remdesivir loading dose 200 mg di hari pertama, karena satu vialnya itu adalah 100 mili, maka diberikan 2 vial dengan diinfuskan dengan NaCl 250 cc, dan lama pemberiannya ini bukan artinya, ini terlihat di slide ada garis miring 3 jam, artinya bukan pemberiannya setiap 3 jam ya, ini mungkin salah cara menulis. Ini diberikan paling lama durasi pemberian infusnya itu 3 jam, bahkan boleh 1 jam, jadi antara 1 jam sampai 3 jam, dan itu loading dose, maka dosis selanjutnya adalah bisa hanya 1 vial saja atau 100 mg saja. Kemudian untuk yang sedang ini bisa diberikan antikoagulan, tadi sudah diterangkan bahwa kita harus melihat juga apakah dedimernya meningkat atau yang lain-lain, jadi ada patokannya juga ya. Dan juga dapat diberikan symptomatic treatment. Baik, untuk yang severe atau critical ill patient atau yang pasien severe yang berat, maka ini memang perlu perhatian khusus ya, karena memang banyak sekali supporting yang harus kita berikan, termasuk pemeriksaan yang berulang kimia darah yang disebutkan tadi, dan juga serial fototorak untuk melihat perkembangan penyakitnya, dan juga perlu dimonitor. Ini apakah respiratory rate-nya sudah di atas 30, saturasi sudah di bawah 93, ataupun PaO2 per fraksi oksigennya di bawah 300, dan apakah ini nanti kemungkinan meningkat dengan pemberian. Biasanya kalau di rumah sakit yang mempunyai NIV atau high flow nasal kanul, kalau masih di bawah 90 kita masih coba tuh. Kenapa kita masih mencoba dengan high flow nasal kanul? Karena pada pemberian high flow nasal kanul ini pasien masih sadar. Dan kalau pasien masih sadar, kita tadi melihat presentasi Dr. Syam bahwa sebaiknya posisi pasien itu adalah yang prone position, jadi posisi tengkurap, maka kalau pasien sadar lebih mudah membuat pasien tengkurap dibandingkan kalau pasien diintubasi, itu butuh 5-6 orang untuk membalikkan badan pasien untuk posisi prone position. Kenapa prone position? Supaya area paru yang bisa melakukan oksigenisasi itu lebih luas. Ya, jadi untuk yang berat dan kritis ini kalau bisa pertama dimulai dengan oksigen 15 liter per menit, bila tidak bisa maka dilakukan pemberian high flow nasal kanul seperti yang saya sampaikan tadi. Kita ikuti selama 1 jam apakah stabil atau perburukan. Kalau dia masih stabil, maka high flow nasal kanul bisa diteruskan. Tapi kalau dengan pemberian high flow nasal kanul yang sudah optimal, tetap tidak ada perbaikan saturasi oksigen atau menurun terus, maka sebaiknya segera kita lakukan intubasi. Ya, ini saya sudah terangkan tadi, tetapi ada satu yang mesti kita perhatikan dan perlu kehati-hatian bahwa pemberian high flow nasal kanul itu ada risiko untuk terjadi aerosol. Oleh sebab itu pemberian pemakaian alat ini NIV maupun high flow nasal kanul haruslah di ruang yang negative pressure. Ya, ini tadi kita masuk kepada pasien yang tidak berhasil dengan high flow nasal kanul setelah pemantau 1 jam pertama dan 2 jam berikutnya, maka segera masuk ke ventilator mekanik dan protokol perawatannya sesuai dengan ARDS dengan volume tidal yang rendah, ya, 8 ml per kilogram berat badan, ya, dengan PIP yang kita lakukan titrasi dan targetnya adalah low driving pressure.
5 menit lagi, Dr. Elina.
Oke, ya kalau juga tidak berhasil, sekarang ada namanya alat ECMO, extracorporeal membrane oxygenation. Tidak banyak orang yang punya. Di Jakarta katanya cuma ada 4, yaitu di Harapan Kita, dan itu sering dipinjam ke Gatot Subroto dan lain. ECMO ini adalah suatu alat oksigenasi darah dilakukan di luar tubuh. Jadi fungsi jantung dan paru dihentikan untuk sesaat, dan kerja oksigenasi atau pertukaran udara dan lain-lain di oksigen dan lain-lain dilakukan dengan alat ini, ECMO namanya. Baik, waktu 5 menit lagi. Ini obat-obatan untuk yang critically ill sama ya dengan yang lain-lain, dan sebaiknya sekarang kita ada penelitian remdesivir ya untuk yang berat juga. Kalau sudah ada remdesivir boleh kita coba ya, karena sudah ada emergency use-nya. Dan juga sama tadi ini sudah diterangkan pemakaian antikoagulan dan dexamethasone. Saya sedikit menerangkan, ada tambahan bahwa kami akan melakukan penelitian tentang remdesivir untuk 25 pasien. Sasarannya adalah pasien yang berat, yang fraksi oksigennya di bawah 94, kemudian tidak ada penyakit penyertanya hepatitis atau penyakit ginjal, dan kemudian juga mau berpartisipasi. Ini kita sudah alokasikan untuk 25 pasien, dan kita ingin melihat efektivitas dan juga melihat safety-nya. Jadi mudah-mudahan ini akan segera kita laksanakan. Demikian, terima kasih Dr. Agus karena waktunya juga sudah habis. Saya kembalikan kepada moderator.
Ya, terima kasih Dr. Elina. Kita akan lanjut ke diskusi. We will continue with discussion, and I will give a question from participant first to Professor Syamsudar. I will give three questions, Prof. One is from Dr. Muhammad Ramadhani Suroso. Can I give remdesivir and lopinavir ritonavir together for COVID-19? This is the question one. The secondly is from Dr. Angga Madro Raharjo.
Dr. Ibrahim, can you repeat the first question, please?
The question one is, can I give remdesivir and lopinavir ritonavir together for COVID-19?
There is no such data in the literature, and I don't think we should be, unless we have some evidence, we should be using this, because these patients are very, fragile, and one wrong step can kill them. So I don't think, there is hardly any data on lopinavir ritonavir combination. Now in the Solidarity trial, this is one arm is lopinavir ritonavir combination, but nothing together. No.
Okay. The second question. Can we use remdesivir not by loading dose? but strict to maintain dose because expensive price. That is still effective.
No, no. I mean, the loading dose is very important because this is the one which decides the level of blood levels. So I don't think you can change the protocol. And it's already now, instead of 10 days, 5 days are good enough. So instead of 5 doses, he has to take 6 doses over 5 days. So I don't think you can do that. No.
Okay. The third question is, which antiviral is best for COVID-19? As you know, Professor.
Which
antiviral is best for
antiviral?
COVID-19? Because many antiviral used for COVID-19. So what the best antiviral for this COVID-19?
At the moment, based on the clinical trials, remdesivir is the only drug which has a very good database. There are many studies, and the second one is coming is favipiravir. So I think remdesivir is at the moment answer.
Okay, thank you. I will go to Dr. Erlina. Dr. Erlina, ada pertanyaan. Apakah remdesivir ini sudah dijamin oleh BPJS? Ini ada yang bertanya begitu ya. Dr. Erlina tahu jawabannya?
Iya. Jadi remdesivir ini karena obat baru dan tetapi dari wacananya akan sebagian dibeli oleh pemerintah untuk didistribusikan untuk rumah sakit rujukan, dan ada wacana juga bahwa harganya akan diturunkan bukan 3 juta seperti yang selama ini diumumkan, mungkin akan bisa separuhnya. Jadi mudah-mudahan kalau harga semakin turun, makin banyak kemampuan pemerintah untuk membeli untuk didistribusikan kepada rumah sakit untuk dipakai. Ya, dan saya juga ingin menambahkan tadi pertanyaan bahwa apakah antivirus bisa dipakai bersamaan. Jadi kalau dari pedoman kita harus memilih salah satu. Dan juga dari pengalaman kalau hanya ringan-ringan saja, bahkan dengan oseltamivir juga sudah cukup baik hasilnya. Dan juga kita sudah memakai favipiravir dan itu juga bisa merupakan salah satu pilihan. Tapi nggak bisa semua antivirus dipakai secara bersamaan. Ya,
yang kedua, Dr. Elina, ini ada yang nanya, bolehkah pasien tanpa gejala atau pasien COVID ringan itu diberikan antivirus?
Ya, kalau yang tanpa gejala itu artinya sistem imunnya sudah cukup baik sehingga tidak terjadi replikasi virus yang lebih luas, sehingga makanya tidak terjadi kerusakan yang cukup menimbulkan gejala. Jadi saya kira mubazir saja, cukup pemberian vitamin. Saya kira dengan vitamin itu memaintain sistem imun untuk bisa mengkontrol virus, dan virus itu juga punya masa hidup ya. Jadi dia juga lama-lama akan kemudian mati. Jadi tidak perlu juga berlebihan kita berikan antivirus. Tapi kalau untuk yang ringan, saya setuju diberikan antivirus. Tapi jangan remdesivir ya.
Ya, terima kasih. Ini pertanyaan ketiga buat Dr. Erlina. Kenapa pemberian kloroquine atau hidroksikloroquine pada derajat sedang dan berat itu dosisnya berbeda dan lama pemberian berbeda?
Ya, jadi begini, kalau yang berat itu terutama kalau terjadi shock, maka pemberian dosis yang tinggi dan lama untuk hidrokloroquine itu malah membahayakan. Tetapi kalau kita tahu pada yang berat ini tidak terjadi shock atau aritmia atau lain-lain, itu masih kita berikan. Jadi untuk safe-nya makanya kita bedakan antara yang sedang dan yang berat, karena mengingat itu masalah yang berat itu sering terjadi masalah di jantung. Ada shock, ada kardiogenik, dan ada juga aritmia. Jadi makanya kita hati-hati sekali memberikan pada yang berat. Demikian Dr. Agus.
Ya, terima kasih. I will continue to Professor Samsudar. This is the next question is remdesivir safe for the pregnant woman?
No data. There is no information is available, and it should not be used in pregnant women.
Okay. So we cannot use for the pregnant woman remdesivir for the COVID-19 with pregnancy?
No.
Okay. The second question is, how about patient with HIV, acute immunodeficiency syndrome with COVID-19? can we give remdesivir?
Yes, we can give remdesivir, but continue the antiretroviral treatment. Do not stop the anti-HIV drugs, and then you can use remdesivir, no problem.
Okay, so we can use antiviral for HIV and also remdesivir.
Yeah.
Okay. The third question is, okay, I will open the and the next question. How about patient with renal insufficiency or chronic kidney disease? This drug remdesivir safe or not if we give patient with renal insufficiency or chronic kidney disease?
Again, the data is not there, but I will not advise giving remdesivir to a patient who is having renal failure. No.
Dr. Agus, saya tambahkan bahwa kelainan ginjal dan kelainan di hepar adalah kontraindikasi untuk pemberian remdesivir. Makanya pada penelitian uji klinis kita nanti di persahabatan juga kelainan pada kedua organ ini akan menjadi kriteria eksklusi.
Ya, terima kasih Dr. Elina tambahannya dalam bahasa Indonesia, semoga lebih paham. This is the third question from Prof. Samsudar, because we use oseltamivir in Indonesia for COVID-19 treatment. Participant ask for your opinion. How your opinion about oseltamivir for COVID-19 treatment?
With due respect to those who are using oseltamivir, actually there is no data which suggests that this antiviral has got any effect on COVID. So there is no studies. So I don't know. It could be just placebo or anything like that. I don't think we should use unless we have definite data. We should not use. Again, as I said, this disease is very, very dangerous. If we do not treat them properly, patient can die. As you know, especially the severe patient and the critical patient. So we should be very careful while using the drug.
Okay, I will going to Dr. Erlina because some question for Dr. Erlina. Ini ada beberapa pertanyaan tambahan Dr. Erlina. Misalnya pasien itu memiliki D-dimer yang tinggi, ya, D-dimer yang tinggi ya. Artinya kita butuh antikoagulan ya. Nah itu antikoagulan itu bisa diberikan dari derajat apa dan antikoagulan apa yang dipilih ya. Apakah enoxaparin atau low weight molecular heparin? Ini pertanyaannya buat Dr. Erlina. Pada derajat ringan ya Dr. Erlina.
Ya, kalau derajat ringan kita biasanya memberikan yang low molecular heparin ya. Dan itu memberikan hasil yang baik ternyata. Jadi tidak masalah pemberian itu.
Ya, kemudian untuk Dr. Elina kembali, ini saya agak bingung nih pertanyaannya. Oh ya, ini bagaimana kalau pada pasien COVID-19 yang sudah sembuh, kemudian tiba-tiba positif lagi? Apakah ini kita tata laksana sebagai kasus kambuh, terus protokolnya bagaimana?
Ya, jadi pasien-pasien COVID kalau sudah sembuh seharusnya sudah punya antibodi yang memberikan kekebalan pada dirinya untuk tidak terinfeksi lagi oleh virus. Tapi lama kekebalan itu memang tidak lama. Dari literatur mengatakan mulai dari 3 bulan sampai 12 bulan. Jadi kalau itu terjadinya setelah 3 bulan kemungkinan itu adalah reinfeksi. Tapi kalau hanya beberapa minggu, misalnya setelah 2 minggu positif lagi, saya kira yang positif lagi itu adalah mungkin alat PCR mendetek hanya fragmen dari virus, atau istilah umumnya, istilah untuk awamnya kita pakai adalah bangkai-bangkai.
Halo, Dr. Elina.
3 bulan. Karena sudah punya IgG dalam tubuhnya yang memberikan kekebalan.
Ya, kalau misalnya tadi dia ternyata udah 3 bulan, kemudian terinfeksi ulang, protokolnya apakah dianggap menggunakan yang awal atau ada protokol yang lain?
Ya, kita bisa pakai protokol sesuai buku pedoman kita, tetapi mungkin saya sarankan untuk pemilihan antiviralnya jangan yang sebelumnya diberikan. Jadi mungkin yang satu di antara yang 3 yang tidak kita berikan. Jadi kalau di awal pemberian oseltamivir jangan diulang lagi, mungkin kita pilih favipiravir atau sekarang ada remdesivir, kita pakai remdesivir kalau memang dia jadi berat atau memenuhi kriteria.
Mungkin saya perlu minta pendapat sama Profesor Syam ya. Profesor Syam Sudar, this is there is one question. How about reinfection COVID-19? Yeah, if patient cure from COVID-19 and maybe 3 months next there is reinfection, how about the protocol to the treatment about the reinfection of COVID-19?
Yes, now there are reports in Lancet. Recently a paper has appeared where 4 patients were reported to have reinfection to COVID-19. So yes, it is possible because the immunity is not very long lasting. Immunity is only hardly for 3 months. So yes, as you said, there is a possibility of reinfection.
How about the treatment? Can we use the same protocol in the first treatment or there is another choice?
No, because we do not know how these patients should be treated because there are so few. So I will recommend that you use the recommended regimen in your own area rather than playing with other drugs, because there is no data and it's never going to be there because there will be so few cases.
Okay. Maybe we will specific consultation for the expert for the treatment in condition reinfection. Okay, this is the second question from Professor Syamsudar. Can we use remdesivir in the patient in mild case with comorbid like the obesity or diabetes uncontrolled?
Yes, we can use diabetes or obesity. We can use remdesivir, no problem.
In the mild case, no problem.
Mild,
but not mild case.
Mild case remdesivir is not actually. I mean, in India, it is not advised, and even the NIH, National Institute of Health guidelines do not say that remdesivir should be used for mild, because it has been seen that it has no effect on mild disease, or similar to placebo. Its effect is similar to placebo. I don't think remdesivir should be used for mild disease. For mild disease, favipiravir is a good drug.
Ya, Dr. Agus, jadi indikasi untuk pemberian remdesivir dari semua penelitian yang sudah terbit itu adalah untuk kasus yang berat. Tidak diuji cobakan kepada kasus yang ringan dan dikatakan tidak perlu pemakaian remdesivir. Jadi kalau kita punya favipiravir atau Avigan mungkin itu lebih baik karena memang bukan indikasinya remdesivir ini untuk yang kasus ringan.
Okay. I will give question for the two speaker because this is about the corticosteroid. One from Prof. Samsudar. How about the methylprednisolone for the treatment in COVID-19? How about the dose of this methylprednisolone for COVID-19?
I think, you can use methylprednisolone, and you have to use equivalent dose from whatever. I mean, if dexamethasone is the best, and dexamethasone is easily available also, but you can use methylprednisolone also.
But if we use the methylprednisolone, can we use the dose 2 times a day with 125 milligram in the severe case?
yes, it should be okay. Yeah.
Bagaimana Dr. Elina?
Ya,
Ini ada
jadi
yang bertanya soal metilprednisolon karena kita
yang
kan
terbaik kan adalah dexamethasone karena ini sesuai dengan penelitian yang pasiennya banyak sekali sehingga itu yang kita tetapi sesungguhnya kita juga bisa memakai metilprednisolon dengan dosis yang ekuivalen dengan 6 mg tadi dan biasanya kita bisa pakai dosis 125.
Ya, terima kasih Dr. Elina. One question again for Prof. Samsudar. About remdesivir and chloroquine, can we use together?
This is again, chloroquine. I've shown you the slide in various meta-analysis. Chloroquine has not proven to be any beneficial. So I mean, I would not use. For me, it is a placebo. I should not be using chloroquine with or without remdesivir.
Dr. Elina, bagaimana? Ada tanggapan mengenai pertanyaan chloroquine diberikan bersama dengan remdesivir? Karena di pedoman kita ada itu. Ya,
jadi rujukan yang dipakai oleh jurnal publikasi luar negeri adalah hidroksikloroquine dosis tinggi. Bahkan WHO memberikan 2 kali 1.600 ya atau 2 kali 1.800, 2 kali 800. Sementara kita di Indonesia hanya memakai dosis 2 kali 400, 2 kali 200 atau 1 kali 400 yang mana ini menunjukkan dosis yang rendah dan tetapi dosis ini adalah dosis yang biasa dipakai oleh orang Indonesia. Jadi sejak zaman dahulu orang Indonesia terutama yang malaria tidak masalah dengan dosis ini. Tapi yang di jurnal internasional memakai dosis yang cukup tinggi ya untuk kita. Jadi itulah salah satu alasan mengapa kita masih memasukkan chloroquine atau hidroksikloroquine ini ke dalam pedoman kita karena kita memakai dosis yang rendah. Dan kita tahu memang bahwa tidak ada satupun obat yang spesifik untuk COVID ini sehingga kita juga tidak bisa mengatakan hidroksikloroquine tidak bisa dipakai. Tapi dari pengalaman kita selama ini dari pemakaian hidroksikloroquine tidak ada bukti yang menunjukkan bahwa kematian itu berhubungan dengan QT interval yang memanjang yang disebabkan oleh hidroksikloroquine. Tapi kita bisa tunggu hasil dari penelitian kita ya, ada beberapa penelitian yang dipimpin oleh Dr. Agus juga kan bahwa ada penelitian hidroksikloroquine di setting-setting yang ada anggota PDPI-nya dan juga ada penelitian dari Dr. Dia. Kita lihat ada yang prospektif kan, kita lihat apakah memang hidroksikloroquine ini bermanfaat. Kalau memang nanti dari penelitian kita walaupun aman, tidak menimbulkan kematian, tapi kalau memang tidak ada efektivitasnya barangkali suatu ketika akan kita tarik dari pedoman. Sekarang kita belum tarik karena memang emergency authorization use-nya masih ada dari Badan POM.
Ya, terima kasih Dr. Lina. Ini karena sudah selesai waktunya, kita masih banyak pertanyaan sebenarnya dan ini mungkin bisa ditampung.
Satu kali lagi serial.
Ya, kita bisa tampung pertanyaannya, nanti bisa disampaikan kepada penanya untuk bisa memberikan jawaban kepada para speaker dan nanti akan diberikan secara tertulis. Karena kita sudah sesuai dengan jadwalnya untuk selesai pada sesi diskusi ini. Saya rasa cukup dari saya sebagai moderator. Thank you very much, Professor Samsudar, for your presentation and discussion. Very excellent, and we hope your explanation can give more information for the participant. Terima kasih kepada Dr. Elina yang sudah juga membantu di dalam memberikan banyak jawaban dari pertanyaan dan juga menambah klarifikasi. terkait juga data-data kita di Indonesia. Saya kembalikan kepada pembawa acara untuk malam hari ini untuk mengikuti kegiatan tambahan selanjutnya. Saya mohon maaf apabila ada yang. Terima kasih.
Thank you, Dr. Susanto.
Yes. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak Dr. Agus. Terima kasih banyak kepada narasumber, moderator, serta para peserta yang telah menyimak dengan baik. Semoga ilmu yang disampaikan oleh para narasumber dapat bermanfaat baik bagi kita sebagai dokter dan klinisi, maupun bagi masyarakat serta pasien-pasien yang memerlukan pertolongan kita. Saya mengingatkan kepada para peserta untuk mengisi kuesioner daftar hadir dan umpan balik yang ada di bawah kolom chat untuk mempermudah kami dalam mengirimkan sertifikat. Sertifikat webinar ini akan dikirimkan melalui email. Nah, sesuai dengan yang telah disampaikan sebelumnya, masing-masing narasumber dan moderator, Dr. Agus, Dr. Elna, dan Prof. Samsundan akan memilih 3 orang penanya terbaik yang akan mendapatkan hadiah. Sembari menunggu, kita akan mendengarkan closing remarks dari Dr. Syam Aku selaku Head of Medical Marketing Hetero. Now, I invite Dr. Syam Aku, Head of Medical Marketing Hetero, to give his closing remarks. Please welcome Dr. Syam Aku.
Good evening, all. The session has been really informative. Before I give my closing remarks, because it's a new product, I would like to give you a global perspective on what is being considered in various countries regarding remdesivir. So, if you look at, of course, all of you are aware that this has been given an emergency use authorization in the US. But when we look at the development, the initial approval for EUA was in the severe disease and for COVID-19. And based on the new data for moderate patients, FDA has now given the EUA for all hospitalized patients for COVID-19. So this is an expansion of the current usage into all these patients, and this is well supported by the evidence. So the current EUA stands for treatment of adults and pediatrics who are hospitalized with suspected or lab confirmed COVID-19. Similarly, when we look at Europe, the initially use was under compassionate use, but now they have moved to the conditional marketing authorization, the CMA, wherein it is similar to the EUA of US. And this is for all those patients who would be requiring supplemental oxygen. So we know that this is a very challenging time. Evidence is being limited, but we know that things are evolving, and remdesivir is well supported with evidence now to strongly position it and use it in these patients who are hospitalized with COVID-19. Again, in Japan, it followed the US EUA, and this has been approved for use in severe patients. So in India, of course, the remdesivir was launched way back in June, and as at Hetero, we are the first company to get the approval for restricted emergency use for the COVID-19 patients. Till date, we have been able to reach out and help more than 1 lakh patients in India. That is close to 8 lakh vials. And in India, of course, it follows a 5-day regimen based on the global evidence. Under Gilead's license, we have the rights to distribute it to 127 countries, and till days we have supplied to over 1 million vials of Covifor or remdesivir for use, including the continents of Africa, the Latin America, Central Asia, and ASEAN regions, and there are 25 countries wherein we are able to supply. So this gives the confidence of heteros remdesivir being used in these patients. And we are stringently following all the local guidelines as well as regulatory processes to make it available for the patients. As it's a new product, just a brief introduction on the product per se. So this is the remdesivir vial, which is for Indonesia use. It is available as 100 milligram vial. It is a preservative-free white to off-white lyophilized powder. So it is available as a powder form. It's a single dose vial. And when we look at the recommendations in Indonesia, for those patients who are more than 12 years of age and at least 40 kgs with severe disease, day one treatment, you have the loading dose of 200 milligram, that is 2 vials, followed by a maintenance dose of 100 milligram per day. And when we look at the duration of therapy, minimum of 5-day treatment. Now we have also seen the clinical trial with severe disease, moderate disease, wherein we are able to see a significant difference with 5-day treatment. However, the treatment can be extended till 10 days based on the evidence that if there are severe patients who are on ECMO or who require any invasive ventilation, probably these could be, there is a possibility that these can be the patients. When we look at the data as well, there has been a reduction in mortality in these patients when we extend the treatment till 10 days. So on that basis, most of the patient might be requiring for 5 days, and few patients might be requiring the extension to a maximum of 10 days. So for a 5-day treatment, the patient would require a total of 6 vials, and for a 10-day treatment, a total of 11 vials would be required. Coming to the preparation, we have the remdesivir as a lyophilized powder. This needs to be reconstituted with sterile water of 19 ml. This has to be shaken for 30 seconds and then rested for 2 to 3 minutes until a clear solution is formed. If not, the process has to be repeated. And this concentrated solution has then to be diluted with 0.9% saline. And this has to be diluted immediately after reconstitution. And then this can be infused. After infusion, flush with at least 30 ml of saline. So after the use. And this is a dilution technique used. So the volumes can be either 250 ml or 100 ml of saline. An equal volume of saline has to be removed and replaced with remdesivir. So if it is 100 ml which is being used for the loading dose, then 40 ml has to be removed, and then you use the remdesivir injection to infuse into the bag and then infuse it into the patient. So coming to the rate of infusion, minimum is about 30 minutes, maximum is about 120 minutes. And if you have an infusion pump, you can set it as per the requirement. So administration time is 30 minutes to 120 minutes for the patients. Coming to the storage conditions, so the lyophilized powder can be stored below 30 degrees centigrade until the time of requirement. After reconstitution, that is, you have the concentrated solution, this can be stored up to 4 hours at room temperature or up to a maximum of 24 hours at refrigerated temperature, that is 2 degrees to 8 degrees centigrade. And once it is mixed with the saline, the diluted infusion solution can be stored for 4 hours at room temperature or can be stored for 24 hours at a refrigerated temperature of 2 degrees to 8 degrees centigrade. So that is a brief on the product. I know it's a new product. You can refer to the information for complete information. And on that note, I would like to thank our moderator, Dr. Agus, Dr. Shyam Sundar, for giving some insights on the remdesivir as well as the new therapy favipiravir, and Dr. Erlina for giving us the perspective from Indonesia. So today, as we see based on data. Now we do know that every day you have new data to support the evidence, because we had initially we had a lot of products which were under experimental use, like the discussion has been of oseltamivir, hydroxychloroquine, lopinavir, ritonavir, and few other therapies are now being evaluated. However, we know that this is a challenging time and data is limited. However, based on these, remdesivir does have a very good data, and this has been supported globally. So definitely this is one product which can be used for all the patients who are hospitalized with COVID-19. Yeah, thank you all. So over to you, Dr. Ibrahim.
Ya, thank you, Dr. Syamaku. Terima kasih kepada Dr. Syamaku. Sekarang saya akan mengumumkan 3 penanya terbaik yang akan mendapatkan hadiah. Jadi penanya terbaik yang pertama bertanya mengenai tata laksana reinfeksi COVID-19 oleh Dr. Yuli Rohayati. Selamat kepada Dr. Yuli Rohayati. Kemudian penanya terbaik kedua tentang pemberian hidroksikloroquine, yaitu oleh Dr. Yeni Putri. Sedangkan untuk penanya terbaik ketiga yang bertanya mengenai pemberian remdesivir bersamaan dengan antiviral lain, yaitu oleh Dr. Muhammad Ramadhani Suroso. Kami ucapkan terima kasih kepada 3 penanya terbaik. Nama-nama tersebut akan kami hubungi melalui nomor dan email kontak yang diisi di kuesioner umpan balik. Sekali lagi saya mengingatkan kepada para peserta untuk tidak lupa mengisi kuesioner umpan balik agar kami dapat mengirimkan sertifikat melalui email. Mungkin Dr. Anti boleh dibantu ditampilkan slide yang berisi cara mengisi kuesionernya, Dok? Atau saya tampilkan saja ya. Jangan lupa untuk mengisi kuesioner umpan balik yang ada di bagian bawah tombol submit ya. Bisa dilihat di layar. Jika Anda mengklik tombol itu, maka akan otomatis masuk ke dalam kuesioner feedback. Baiklah. Kita sampai pada penghujung acara. Saya mohon kesediaan para narasumber, moderator, serta peserta panitia yang lain untuk dapat mengaktifkan videonya dan melambaikan tangan untuk kita ambil screen foto sebagai dokumentasi webinar pada malam hari ini. Mohon Dr. Elina Burhan, Dr. Agus Susanto, Profesor Syam, Dr. Syam, Profesor Samsudin, and Dr. Syamaku, please wave your hand to the camera because we will take the screenshot for the documentary for the next webinar. Dr. Syamaku, can you wave your hand? Yeah, okay. Mr. Sandip Sior. Yeah, okay. I will capture the screen. Okay, thank you. Baik, saya ucapkan terima kasih kembali kepada moderator, narasumber, dan peserta. Semoga ilmu yang kita dapat pelajari bisa bermanfaat, tidak hanya untuk kita sebagai dokter, tapi juga untuk semua orang yang kita tolong di masa depan. Akhir kata, saya mewakili panitia yang bertugas menyampaikan mohon maaf atas segala kekurangan dan kekhilafan dalam penyampaian webinar ini. Terima kasih banyak. Wassalamualaikum warahmatullahi wabarakatuh. Salam sehat untuk kita semua.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih Dr. Agus. Panduan acaranya. Dr. Erlina, terima kasih banyak atas masukan ilmunya. Thank you Dr. Syamsundar.
Thank you, Prof. Syamsundar.
Dokter Nanti,
Ya, Dok.
ini barusan ada yang WA saya, ada pasien kritis di Medan minta punya akses terhadap remdesivir. Ini saudara dari Menhukham apa gitulah.
Oh,
mungkin dia
oke.
nonton. Jadi saya kasih nomor penghubungnya ya.
Ya, boleh Dok, boleh.
Pakai harga baru ya.
Pakai harga baru, ya. Harganya sudah mulai dari kemarin sore, Dok.
Oke, saya izin dulu ya. Terima kasih ya.
Iya.
Terima kasih banyak Dr. Agus.
Ya.
Bye.
Ya, baik. Terima
Terima
kasih,
kasih
Dok.
Dr. Elina.
Terima kasih,
Thank
Dr.
you
Ibrahim.
everybody. Terima kasih Ranti. Izin live. Thank you Prof. Thank you Dr. Syam.
Thank you all. Thank you.
Thank you, Dr. Sam.
Thank you.
Bye.
Bye. Have a great day.
Have a great evening.
Thank you.
Thank you. Still recording? I think should be stop ya.